When we are examining the behavioral or psychologic emergency patient, there's a few extra things we want to look at when we're looking at their mental status. Of course, we need to make sure that the scene is safe. That's the same that we do for every call, every patient. But when we approach the psychiatric emergency patient, we want to begin by looking at just sort of their posture and their demeanor and how are they standing. Do they seem to notice you when you come in? Do they look like they're being aggressive or hostile? Do they seem calm? Are they well groomed? Or do they seem a little disheveled when you walk in? Just a couple things to look at initially. When you're talking with them, see if their speech pattern is normal or not. Sometimes they may not connect words that make sense. They may have slurred speech, which could indicate other things other than a psychiatric emergency. Do the sentences seem to follow some sort of common sense, not common sense, but common form and function of a normal sentence? Or are they just saying words that are not connected and seem very confused about what they're talking about? We sometimes call that a word salad, where they just sort of are saying all sorts of words, just back to back, and none of it really seems to make any sense at all. As with all of our patients, as part of our patient assessment triangle, look at their skin to see if it's normal looking, or is it pale, is it sweaty, is it flushed? Just your general impression of the patient with that. And as you're doing that, look at their posture. Are they leaning? Are they standing upright, slumped over? And if they're walking around, look at their gait to see if they're walking normally or not, because that sometimes can give an indication for something like a possible stroke or TIA, Parkinson's disease. Sometimes even with dementia, you see a bit of a shuffle. So maybe that could give you some clues. Do they seem to be oriented to what is going on around them? Again, did they look at you when you came in? Do they know where they are, what happened? We use that as the alert and oriented times 4, person, place, time, and event. But just are they oriented? Check their memory. See if they know what happened to them, if they have memory of the event. See if they have longer term memory, like can they remember their family member names or spouse's name? We like to use the president one, but with the way political climates are nowadays, there's a lot of people that say that's not my president, so I don't always use that one anymore. Sometimes I'll give them like 2 or 3, 4 words to try to remember, something like tree, bird, green, and car. And then I'll ask a couple other questions like, can you tell me your birthday? Can you tell me your phone number? And then I'll come back and see if they can remember those words. And that lets me know if they have good memory or not. Some people will have memory of events leading up to the incident. Some people have memories or no memories before the incident, but only after the incident. And then some people, especially with like Alzheimer's and dementia, may be able to remember things from early childhood very well, but not so much current events. What does their body language look like? Do they look friendly and welcoming and warm, or do they appear hostile or scared? Do they pull back from you? Are their hands up in a defensive posture? Or are they having any involuntary movements with their body? Sometimes medications and other conditions can cause some involuntary movements, so that might give us some clues. Do they seem to have some sort of delusion or hallucination? And remember, this could be a visual one. They see things that are not there, or it could be an auditory hallucination where they're hearing things, like hearing voices that the rest of you aren't. And I usually address that by saying something like, I know you are hearing that, but I am not hearing that. Or I know you see that, but I don't see that. I don't necessarily want to discount what they're seeing or hearing, because that could, again, make them very defensive. But I want to let them know that the rest of us are not seeing that, so it may be that that's an hallucination that they're having. I also like to try to make a judgment on their mood or affect. Sometimes a very flat affect. They just have nothing really going on with their face. Or are they very animated or excited or agitated? And try to figure out that, or are they depressive? And then we have to worry about suicidal, and we have to ask those questions. So try to figure out their mood or their affect. And finally, are they judging things correctly? Are they realizing that this action leads to that action and the cause and effect of that? Do they understand why things are happening to them the way they are, why you were called, why you want to take their blood pressure? But anyway, it's just their judgments on things. So I hope that helps with a little bit of your psychiatric emergency or behavioral emergencies when we're looking at a patient and first beginning to assess them. Some things kind of above and beyond our general impression of the patient.